Now I want to introduce you to an innovator in employee healthcare. Brian DeVore is the Director of Strategy and Healthcare Ecosystem for Intel Corporation. That's one of those titles that I think inspires you to ask, what does that really mean? But I think what it means is that he provides the guidance for strategy. He's responsible for the national and local partnerships that are necessary to provide innovative healthcare to Intel employees. He works with senior executives in healthcare and technology, as well as business and government leaders, to drive changes in care, payment methods, data, and organizational structure that we know are necessary to provide better quality at lower cost. He serves on a number of advisory and board positions, including the Oregon Health Policy Board, the Pacific Business Group on Health, and the Oregon Coalition of Healthcare Purchasers. He has served as an advisor to the National Governors Association State Allowance for eHealth, the Texas eHealth Alliance, and the Oregon Health Information Technology Oversight Council. Very importantly, he's a leader in benefits design that puts the employee at the center, and he helped lead Intel's research into what employees really value in healthcare and in health benefits. Please welcome one of Oregon's innovators in healthcare, Brian.
All right, need to check. Is this on? That wasn't you. That was me. It was on during your presentation. Well, thank you for having me. So hopefully we'll try to make sense out of this whole what's an employer doing here, especially at a patient advocacy meeting. And so what I will do is try to frame the picture of where we're coming from, and then I'd like to open up the questions at the end if you have time, and actually get more out of a dialogue than I do get out of a monologue. So. Intel, I'll tell a story and try to bring you along as to kind of where we've been. We're the biggest employer, one of the biggest private employers in the state of Oregon. We have about 15,000 people. I think depending on the day, Providence might actually be bigger, depending on how many people you hire versus us. We'll have 4,000 more people joining us at Intel in about 2 years once the cranes all come down out in Hillsboro. I think we put the entire construction industry back to work in Oregon. But it's good in the sense that we've invested in our community. Oregon is a key state on the roadmap of our technology, and so it's from my perspective, we're invested in the community in Portland. For the most part, we have about, again, 15,000 people, about 45,000 covered lives. So we're not big like PEB or OEB, but we're big enough that folks do pay attention when we like certain things, and so when we ask. Most healthcare systems will listen, sometimes kindly, sometimes they don't listen very well, and sometimes they listen very well. And so on behalf of Intel, I want to say thank you to Providence for being very good listeners. I know we have pulled these guys around, especially the leadership. We've yanked them around as we try to figure out what we're doing. And I think that's one of my messages is we do not have a silver bullet. You'll hear from us a sense of frustration, a sense of we have people who are not getting the care they need. We have people who like you've mentioned before, are non-navigated. They don't know where to go, especially when they get sick. But again, if at 45,000 people, you're bound to have enough people that get sick during a year. And again, we would like to take better care of them. We started about maybe 8-9 years ago with the strategy really to go and do what most employers have done. And that's do consumer-directed plans. So that's moving everybody off of what would be traditional plans into more of a financial alignment so that there's some sense of consumerism and people care about what they consume. And we put on-site clinics, so we actually have people at staffed sites at 5 of them around the nation. We have actually 2 in Oregon, one at the Ronler campus and then one at the Jones Farm campus. And then we have one in Arizona, well, another one opening soon, and then we have one in New Mexico. I think it should be 5. And we also do the Health for Life checks, which is your blood draw, and we weigh people and give them their diagnosis and their numbers. And for the most part, we found that we've made pretty good progress. We have about 70% of our people in a consumer plan, which is good, but bad. And I'll tell you why it's bad in a second. We have on-site clinics, which are great because people can get access to health care, especially when they can't get into their physician. And that's been a problem, honestly. Getting into a physician, I just tried to call and get a physical, and I was told, let's book in December, right? So everybody knows that problem. And so the clinics are good, but they're bad. And I'll tell you why in a sec. And for the most part, we got about 60% of our people getting their numbers, right? They get the vampire every year, and that's good. But the opposite of that is there's a bad side to that. The bad side from the health plan side is that for the most part, people know the financial reasons why they choose care. They've run through the spreadsheets. They've made all I could get nothing this year, I might get a laceration, versus I might get brain cancer this year. And we have engineers at Intel who, I don't know, they must have extra time on their hands, but they're very smart people. I think we hire more PhDs in this country than anybody else. But they run through these spreadsheets at annual enrollment. It's just amazing to go see. And then they put them on these websites, you can go and access them. And it runs through every possible combination you could have. You have no kids, and here's your salary grade, to 15 kids, and lacerations versus brain cancer. And at the end of the equation, at the end of the spreadsheet, it tells you, hey, you should be in a high deductible plan because here's the best option for you. So they've made the decision on financial basis only. When you ask that person, who's your doctor? They have no idea. Most people have no idea. They know that they're financially okay. Doesn't matter where I go, but back to your point, it's when they need the doctors is when they go. And most people in this country, was it the last number I saw, 70% overestimate their health. They think they're in better health than they actually are, so they just don't go. And so there's no connection there. The on-site clinics are great. It's great to have them on-site, but what that does is it disintermediates the local connection to providers. And so we found over time that it's great to have access and people can come in, but there's no continuity. And without information flow, if you go into a center and they do a throat swab and it's a strep, quick strep, and it's not strep, problem occurs 2 days later, you go to your regular doctor, what's he going to do? He's going to run a strep test. Why? Because the information didn't flow to your doctor when you need him. And so what we find is the centers, although good for access, actually cause potentially more cost into the system than less cost. And then the last piece was the fact that in the health centers, the consumer plans, what was my last point? I had the third point. I'm going to lose it here. Too many rabbit trails. Anyway, the point is that we found that for the most part, healthcare works pretty well for those who don't access very often. It doesn't work very well for those who do. And we have not a lot of sick people at Intel, but we have enough that it matters. My spend is about $500 million a year, so we spend almost $1 billion a year on healthcare. So we'd like to get better value for our money. So if we look at what we did for the last 5 to 7 years, we didn't really change very much. And so about 3 years ago, we set a goal to have the healthiest workforce in the world. And we think we can use that as an advantage to attract talent. Our average salary at Intel across about 100,000 people is $125,000 a year. So we pay really well. And we'd like to get them to be the happiest and healthiest workforce in the world. So how do you go do that? Well, you can go and do traditional employer stuff, which in my sense, I'm not an HR guy. I sit in HR now, which is kind of weird. But I think most of the time they do everything wrong. And that is because they dabble in things that they just try to plug holes. And plugging holes hasn't worked. And so we've decided that we are going to go and blow up the system in some sense. We're going to get our hands dirty in healthcare a little bit. We don't want to go do that, but we kind of have to because we really haven't seen the kind of value. And it's not that we again, don't trust the system. We want to go work with the system to try to kind of reinvent healthcare. So about 2 years ago, we decided that instead of going out and doing what HR typically does, which is have the mentality that we're very smart people. In fact, we're smarter than you are. If you just trust us, and we'll give you what you need. We decided that we would stop that process. And we did something that you'll hear about, you mentioned a little bit at the beginning. We stopped the process and said, we don't think we know our employees very well. We think we know our employees, but we really don't know our employees. So what do? Well, most people will go survey their employees. What do you want? And again, if it's just framed around the financial piece of it, they'll say, oh, I want a $5 copay instead of a $10 copay. But when you really ask questions about their care, they have no idea how to answer it. We just found that when you ask an employee to envision a better system, what does a better system look like to you? What does healthcare in 2050 look like to you? And you think you'd get these answers of, well, it would be this and this. They were so mundane that it was extremely disappointing. Here's the answer. Here's some of the answers they came back with. Well, currently I wait 45 minutes in the waiting room. The future would be like I wait like 10 minutes in the waiting room. That would be like the best future ever. And you start realizing the threshold is so low, their experience has been so poor from when they engage the system that the benchmark is just incorrect. Instead of saying, wouldn't it be great if when you showed up at your doctor, they knew who you were? They never asked you for your insurance card because they already had the information. And there was no waiting room. They just seated you right away and you got your care, taken care of immediately. Those kind of things that we expect and we get from Amazon.com and we get from other experiences. In fact, your pet might get it, right? You may not get it. When you begin to get them to think, then they got it amazing. Then their eyes were kind of opened and they began to give us feedback on, it'd be great if this happened, right? It'd be great if you got my Fitbit details into your medical record. And then you'd know, when I ask you ask me if I've been exercising, you could see the data. You'd know I'd been exercising. Or if you ask me if I've been eating correctly, I'd love to send you my Weight Watchers data, right? I could track it anyway. Why can't you look at that information? And so you kind of get this positive, actually it's a negative, positive feedback loop going where their mind is open. And so that was good. So we interviewed them. And then we did something which I think is a little unique. We actually hired a company out of New York called the Futures Company. And they're an ethnographer company, and they study people, basically. What ethnography is, just looking at people. And we asked them not only to interview our employees, but actually go live with them for a few days. And so they actually moved into our employees' homes and observed how they used care, how they got information. And what they found was the employee told us they wanted and needed is not at all what the problem was by observation. And a good example, I've given this before. If you've heard this, I apologize. When surveyed, do you take your medication? Most everybody says, sure, I do. When an ethnographer sits in your house with you and says, do you take your medication? And you say, yes, I do. They say, where is it? Can you show it to me? And most of the time, people couldn't show them, which means if they couldn't find it, they're not taking it. And you wouldn't know that without observation. Another example we use is, where do you get your health information? People say, people always say, I go to WebMD, I call my doctor. These what we consider more ethereal. I'll ask this group because it's kind of a fun conversation. Do you know where people get their health information from? Their neighbors and relatives, right? They walk out the door and they go, hey, Joe, cutting the grass across the street. I got a heart issue. Who'd you go to? I went to Dr. Smith of Providence. You like him? Is he good? Oh, I love him. Great. That's how they choose a doctor. Now, is that the right way to choose a doctor? Probably not. Right? You don't have no idea about quality. You may be coming from a very, very different perspective of what quality is. And so by observation, you can, rather than us go design WebMD or something else that's really up here, people are pretty relationship oriented in healthcare. And so we decided to use those data points. And then the final one I'll use is, as an employer, people don't care about me. If you work for me, you don't care about me, really. I mean, it's just the benefits guy, right? And so I give things to you. I can message all these great things. I can put wellness programs in place. I can give away points. For the most part, I'm going to say 90% of it's a waste of my time, all right? What I'm trying to go do is tie the relationship back to the provider, get that patient and the provider hooked together and set the system. We'll talk about that in a second. So the long story to all these little points I gave you is instead of us coming at the employees and saying, here's what we're going to give you because we're very smart people, here's what you want because we're telling you what you want, we tried to listen. And one of the things we heard was the doctor is the number one change agent. So they're the person, if given the right venue and the right message, they're the ones that can have the change of behavior. So as an employer, I can tell you to stop smoking, I can tell you to lose weight, I can tell you to, for the most part, it's not listened to. Because there's viewed that there's some ulterior motive on my part, and even though I don't think there is, I mean we certainly want a good benefit and a good cost structure. Our number one capital resource and the most expensive and the most dependent thing we are upon in our company is our intellect of our people. You can't design these great chips that go into your computers and your iPhones and other things, well not your iPhone but your phones and stuff, without really smart people. And so we really decided that we were going to go and focus on the most important asset of the company, and that's the people. So this is all kind of culminating. We're getting all this data. We just start realizing that the contrarians and the troublemakers in the group, which is me, say that most of the stuff doesn't work. And what do we need to go do? Well, we decided to go and create a relationship with the provider directly. So we decided to remove the insurance company from the equation and just pay them and contract directly with them. So we created a conversation between the buyer and seller of care. You're the experts in care. If you're a care delivery system, we're just the buyer of care. So we were very specific on what we wanted. We wanted, again, the medical home is exactly what we're looking at. You can call it a medical home. I just call it proactive primary care. You're front-loading everything back down to as much as you can toward the primary care doctor, making them a quarterback of your health, and then allowing that person to bring in the specialists and the team necessary to deliver that care. And there's an assumption that if done correctly, that should obviously first impact health. Two, probably our costs will go up a little bit because you get people in the system who wouldn't be in the system. That's okay. But over time, you'll see a trend downward. So we decided to go do that. We didn't choose Oregon first for a variety of reasons. We decided to go to New Mexico first. And we have a big site there. We have big sites in Oregon, Arizona, and California too. And we decided to roll this out and try it with our population of about 7,000 to 9,000 members. It kind of varies down there in New Mexico. And odd conversation. Providers have never really had a conversation with employers. They typically go through somebody, and we have this really weird connection. And then it's like the care, which is the most important, gets footballed, and it just becomes a financial conversation about networks and pricing. And we were kind of clearly laying out very different metrics and ways of paying. And so I thought that was novel. We decided that instead of the 800 measures of NCQA certification, that's important, we just picked 5. I only care about 5 things, and they're really member-focused. Again, if you keep thinking from the employee's perspective, and from an employer's perspective, I'm trying to help them solve their problems. And the one thing they have a problem with is time. Employees would like to be healthy. They'd like to do all these things. We keep telling them. The doctors, keep telling these people to go do these. And the biggest barrier we heard from our employees was time. And observationally, you can see that. Most of my sick people at Intel are not the employee. It's the member. It's the spouse. It's the kid. So I can go message all I want to the employee, send all the letters I want to the employee. That's not the people that are sick. Usually it's the female head of household, They're managing everybody else's health, kids' health, their health. The last person that's on their list is themselves. And that's how you have to target, again, what we message and how we design it. And so we decided to go work with Presbyterian Health Systems out of New Mexico. I think it's been an interesting partnership. For the long time with the direct contracting, they say, hey, listen, we want to go do a lot of this kind of care. We want to go do what you see on there, but we don't get paid for it. In fact, if we do some of the things that are on there, we don't get paid for it. So you've got to get the business model correct. And so we actually stepped up and said, fine, tell us what it will take to get that without the insurance company in the middle. Let's just figure out if that means no pre-auths. I mean, you tell us what that takes to get there, and we'll go there. But there's a caveat, and that's the 5 measurements. You can't, one's on cost. Basically, it's the triple aim in a very simple way. It's better cost, it's better access, and it's higher quality. But you can't, I call it a scorecard, but it's kind of like your kid's report card. You get a grade point average. Think about it, you have 5 classes. A simple analogy. You have 5 classes. If you want to get paid more than you would have gotten paid, so you want a bonus from Intel, you got to get a 3.8 to 4.0. Now, if you just want to get what you would have normally gotten paid, you get a 3.4 to 3.8. If you go below that, you give me some of my money back because the quality or something has suffered in there. So what that does, that keeps the provider systems on their toes because they can't say, let's just go give Intel the best cost in the world. Let's just jack the prices down, meet their needs, and nail that one at the expense of quality and access. And we can't just go give them, the red carpet treatment to get in the door quickly and have this great, I got in very fast, but the price was 3 times the price and the quality suffered. It's that you got to hit all 3 at the same time. And that's been a challenge. And so we decided to go and pay differently and then measure differently. And the direct contracting piece, again, has been interesting. The program launched on January 1st of 2013, so it's been going about 9 months. Data's just coming back. We're stuck in this really kind of horrible time cycle of claims. But there are some things we actually can measure in real time. You don't need claims data to do a patient survey, and we survey patients in 3 different ways. We use the PAM survey, which is the patient activation survey. We use a would you refer here, and then we do a 2-day after you went there, how was your visit? Because people have a couple days to think about how was the visit, right? And they walk out the door, you do a quick survey, would you refer your mother there? Most people will go, that's horrible. or I waited, or those kind of things, and that's the one survey. And so I think you get a better, rounder picture of kind of the experience, and you don't need to wait for claims on that kind of stuff. And so what we found, some of the highlights were 60% of the people chose this plan last year, and this was you get this medical home model, and one of the deals is, you're going to go, you get to pick a doctor, otherwise you don't get the deal, and that's created this weird dichotomy of, I don't need a doctor. Well, go get one anyway. I mean, at least start that relationship, and because I think once you start the relationship, then you trust, and then communication starts. Part of the reason I think there's no trust in that relationship of every now and then, which I think was a great story. So 60% of the people signed up, and about 80% of the people have actually picked a doctor, and they better hurry up because they got about 2 months left here to find a doctor. And those are the people that we know. I mean, I have the same problems everybody else does. The ones who are the triathletes and the proactive people, they're probably on day 2 or already at their doctor's office doing what they're supposed to have done. And the people who know they're sick or don't want to know they're sick, and they don't need a doctor to tell them, because when they go and stand in front of the mirror naked every morning after a shower, it's very clear that there's something wrong. You don't need a clinical opinion on that to go make that kind of just observation. And so I think those are the people that are still lagging. But again, you don't get to go next year if you didn't go do what you're supposed to this year. So those are kind of some of the high points. People liked it. 60% of year 1, people signed up and said, I think I get it. I'll do it. And 75 to 80% of people who have started the conversation with their primary care doctor. So they've got in this model. And we have put the business model in place so that the system has now got them, and they're going to hound them. I can stay out of that conversation. I don't need to message anything. Once the system works, we think referrals from other employees, hey, I got this, did you get in? I got in within 10 hours. I got a same-day appointment. I got in like now, or I could go online and schedule my appointment. Those kind of things, I think, begin to sell it, and then I can kind of step back and let it work. Negatives. It has not all worked perfectly. Access has been a problem. So everybody know how bad the flu was this year in Oregon? Well, it was worse in New Mexico. They had massive outbreaks. People couldn't get in. So the provider of record said, hey, it's not fair. That's not fair. We're measuring speed to appointment. Actually, we're not just measuring speed to appointment. We're measuring speed through appointment. So it's not that you just get in quickly. I don't want you sitting in a waiting room for 45 minutes. Well, you sit on this cold, ice cold chair, and nobody talks to you. And then somebody comes in and takes your blood pressure and your vitals, and then they disappear for another hour. We're actually going to find out if that was a good experience for you, because there's just no reason for that. Anyway, access has been a problem. And the provider said, hey, it's just not fair. It's not fair for you to hold us to the same standard we agreed to at the beginning of the year, because the flu hit. And we're just overwhelmed with people coming in for flu shots, and we can't see everybody. And I said, hey, wait a minute. Virginia Mason out of Seattle did some amazing stuff. Here's how you solve your problem with the flu. Set up a phone booth out in front of your hospital, give a guy about 3,000 syringes, and just drive by and have him roll up their arm and just give him shots out of a window. And that happened in Seattle. And they unclogged their clinics in a matter of hours. People just stopped coming in, because what they were coming in for was the visit. Now, they obviously had to figure out the financial arrangements to make that worthwhile. Someone had to pay for that. But the point is that the system became innovative and thought outside the box to solve the problem on behalf of the patient. So the people that were in there that really needed to be seen by the doctor actually got seen by the doctor. And so we kind of pushed back, and we just kindly said, no, unacceptable. Figure it out. And they unclogged their pipe. And so that's really kind of where we're at. We're coming up on year 2 in New Mexico, and I have a year off to plan what happens next. But it's probably one of 3 sites is where I'm going next. And it's either Arizona, Oregon, or California. And it's not California, so it's one of the 2. And why I'm here probably gives you, I can't say anything, but that's probably why I'm here. Yes?
I'm wondering, is there a penalty for Intel employees that are sick for needing to go see the doctor? I mean, other than loss of wages, are they penalized for needing to take sick time off, other than their wages?
Good question. So let me try to answer that. Intel is a majority of non-manufacturing, so we're mostly in Oregon, we're mostly white collar. In New Mexico, actually, you're blue collar, which the blue badge. It's you're manufacturing, you clock in and clock out. You have a shift. And I don't know the answer to that question, whether you were penalized. I don't think so. We're pretty lenient in that respect. In fact, on my side, I don't clock in and clock out at all. So there's no way for me to even measure productivity. But from the manufacturing side, where you do have that hourly wage, it's a very good question. I don't exactly know how we've compensated for that. If there's someone needs to leave to go to the doctor, I think I think there's a pretty lean policy on that in the sense that if you need to go, you can still go, and you're probably paid for your shift, but I can double check on that. That's a very good question. So anyway, with that, I'm going to stop my story. We can take some more questions. Again, I don't have a silver bullet. This is a experiment in process. We'll just keep changing and iterating or making new iterations as we go.
Thanks. It's really refreshing to hear an employer is doing some really out of the box thinking. So thanks. I'm interested in knowing whether or not in the place where you've put this plan into effect, whether you've encouraged your employees and the provider groups to work together so that there's patient voice and family voice in their redesign of how they're doing things.
I should know that, but I don't. I think there is, like Presbyterian has a patient advisory panel. Now, specific to Intel, I'm sure they've got people on. I don't know the answer to that question, though. I know that, most of the people here locally, and Providence has got several, because they ping me, they ask me questions. There have been several Intel people that have sat on the local one here. We're the biggest customer in New Mexico, so I would be shocked if it's not being included. We also have people that send comments back up to us. So we have it's called Employee at the Center group. All we do is figure out how to make what we do and offer a better place to work. Because again, if you're competing for talent, and we do compete for talent with Google and Yahoo, Facebook, you have to offer certain things. And so the employee voice is very prevalent, not just in healthcare, in 401k, in pay, benefits. We do tons of stuff for people, movie pass. So there's a big circle there as far as that. From our side is to get people's input. So Employee at the Center now is circling back with those employees from New Mexico that participated the first time through, and we're going to find out what they liked and didn't like, and what worked and didn't work, and then adjust from there. So I'm assuming the provider's doing that. I don't know for sure, but I know we are.
Thanks. Two things. One is, could you let somebody know if there's anything published that we can follow up with after your talk, and they can spread it out to us? The second thing is, and maybe you have a different way to break it down, but I'm curious how much of the cost you see are occurring because of the outpatient family practice side of things versus specialists and hospitalization. Is there a rough percentage breakdown on that, 80-20, 50-50?
So, first question, yeah, I can get you a white paper. We actually decided to go publish a white paper. I had so many employers calling me and other health systems around the country calling me. We're not new. This has been tried before. We're just tweaking the levers a little bit differently. And I'll send it, and you can pass it out if you want. It's for public consumption. The second question, I don't have the exact numbers, but it's heavily on specialists. We have it's a high deductible plan. You can kind of go wherever you want. There's no gatekeepers. We have a very low percentage of people who've touched a primary care doctor. Most people have one for their kid. They have a pediatrician. You can debate whether that's primary care or not. I think most people would say it is. And most females have picked an OBGYN, which they may or may not even use for primary care. Most of them actually do. And so that kind of confuses it a little bit. How are you counting those numbers, right? So if you go to OBGYN, it's not primary care. Someone may say, but she does my blood draws and everything else anyway, and I like her. She delivered my 3 kids, and she was there when I was at my absolute worst. And I'm not leaving to go to your primary care, your designation, because she kind of does that. So I'd say it's 30-70, 30% primary care, 70% specialist. Tons of our conditions that we measure for so back up, with those things we measure on, we actually read our numbers. We have 7 conditions that are the same as what you guys probably know. It's obesity, it's high blood pressure, COPD, asthma, all the stuff that the community at Oregon and PEB and OEB watch. Same things we watch. We just don't have the prevalence of like cancer, and it's not quite there yet, thankfully, at Intel. But people go to specialists. They go direct to what they think is best. And then I hear about the horrible experience because they kind of self-refer. There's nobody there navigating them and coordinating on their behalf. And so the model that, obviously locally that Providence is rolling out and that the Presbyterian rolled out, and a lot of these systems are moving to a medical home model, is much more of a coordinated and navigated model. It does rub a little bit with Intel's employee population, which is really odd, which is leave me alone. Just give me my money and get out of my face. But that we can't design for. I would consider that the anomaly maybe. Most people just want to have someone buy them when they need them. The analogy I have is we're asking doctors to put that. You know that commercial that Fidelity has, the green line thing. Are you following the green line? I think it's a great commercial because it's one of those. Oh yeah, should I buy this new sports car? Probably not. I won't be on the green line anymore. I'll be on. And your financial advisor can tell you, based on when you want to retire, what your rate is. They can tell you this is your plan. You need to save $15,000 a year for the next 40 years. I mean those, right? In healthcare, we haven't done that, and I think we're asking doctors to do that more. Which is when you come into a medical home model, you should have a health plan, and I don't mean the carrier. You should have a health plan, which is, hi, you're 25, you're bulletproof, everything looks great, see you in 5 years. If you're 55, it's very different. If you're 60, 62, 65, it's a very different plan, which is I'll see you in 2 weeks. If you're diabetic, it might be I'll see you in 2 days. I'll see you in 3 days. But we find that most people don't have a plan from the doctor. It's them reaching back out to the doctor saying, Doc, what do I got to go do? And then the doctor responds, but there's not that, it's silly, but it's that kind of the green line, which is, are you on or are you off the health plan that I have for you? Again, the chronic conditions do a better job of that because that's specialty driven. More primary care doctors are starting to get that in their wheelhouse that, hey, I can manage this. It doesn't need to go to an endocrinologist. I can do it here. So, that answer to your question? Long answer to your short question. I think that's it. With that, thank you for having me.